Let's read arthritis. Guys, what are all the arthritis which is more common in males? Osteoarthritis is more common in males. Ankylosing spondylitis is more common in males. Almost all the bone tumor are common in males, and Dupuytren contracture is common in males. Regarding female, what arthritis is more common? Only rheumatoid arthritis. Psoriatic arthritis has neither male predominance nor female predominance. So I am not writing psoriatic arthritis here. But regarding bone tumor, is there any bone tumor which is female predominant bone tumor? Since I use the word bone tumor here, I got to write the female predominant bone tumor. Do you know any female predominant bone tumor? Any bone tumor which is female predominant? Do you know any bone tumor which is female predominant? Okay, let me tell you. G for girl, G for giant cell tumor. F for female, F for fibrous dysplasia. A for anti, A for angel, A for aneurysmal bone cyst. Clear? Clear? So there is only 3 female predominant bone tumor. One is giant cell tumor, another is fibrous dysplasia, another is aneurysmal bone cyst. Will you ever forget this? G for girl, G for GCT. G for F for fibrous dysplasia, F for female. A for angel, A for aneurysmal bone cyst. Will you guys forget this? These are the only 3 female bone tumor. Female bone tumor. Okay. Coming on to what are all the joints which are affected in osteoarthritis. Joint predilection in hand. In hand. Osteoarthritis affects DIP joint predominantly. PIP joint involvement is there, but it always spares metacarpophalangeal joint. Why this is important? Because there will be question asked. A 60-year-old gentle lady comes to you with a multiple painful joints in the hand. Our mind will think of rheumatoid. And then the question will further say, the patient is complaining pain in the distal interphalangeal joint and proximal interphalangeal joint and first carpo-metacarpal joint and no involvement of the metacarpophalangeal joint. What is your diagnosis? The moment there is multiple joint involvement in hand, our mind goes for rheumatoid. But is the answer rheumatoid? No. The answer is distal interphalangeal joint and proximal interphalangeal joint involvement with metacarpophalangeal joint sparing. So the answer is osteoarthritis. If it is a rheumatoid, they will be giving this pattern. They will be giving a different pattern. What pattern they will be giving? What pattern they will be giving? If it is a rheumatoid arthritis, they will give most common joint to be involved is metacarpophalangeal joint and the distal interphalangeal joint is paired. Distal interphalangeal joint is paired. Guys, I am just talking about joint predilection. I am not talking about symmetrical involvement, asymmetrical involvement. I am not talking about anything. I am just talking about joint involvement. Okay. Coming on to psoriatic arthritis. Psoriatic arthritis, DIP is involved, but any joint can be involved. Which means psoriatic arthritis doesn't spare anything. It can affect any joint. So even if they are giving you a hand x-ray or a hand finding and if that hand is affected, the DIP is affected, it means you can comfortably rule out rheumatoid. It is either osteoarthritis or psoriatic arthritis. If there is MCP involvement, you can comfortably rule out osteoarthritis. It is either rheumatoid or it is psoriatic. Clear, guys? This idea is very important. So don't think that this is something less important. This is very, very important. At the end of arthritis and bone tumor, I will take you through at least 20 questions. Okay. I want you guys to answer the 20 question. Okay. Clear, guys? Because these are all asked questions, guys. These are all asked questions. The most common joint to be involved in osteoarthritis, hence DIP. If they didn't mention any of this, which means they are not worried about degenerative hand arthritis, they are worried about degenerative large joint monoarthritis, then the answer becomes knee. Okay, if the option is having DIP and knee joint, which joint arthritis is more common? Actually, hand joint arthritis are more common than knee joint, but knee joint arthritis is having a surgery, so we are dealing about knee joint in our OPD more common. And in India, no one is worried that I couldn't do this movement with my finger. Will patient complain? No. So DIP arthritis are never reported, but that is more common when compared to knee arthritis. If they are asking which is a more common mono arthritis of joint, then you can answer knee joint. If the option on osteoarthritis has DIP, PIP, first CMC, knee joint, then the answer has to be DIP. If the question says mono osteoarthritis, then you can talk about knee joint. Rheumatoid, irrespective of the whole body, the most common joint to be affected in rheumatoid is metacarpophalangeal joint. The most common joint to be affected in psoriatic is DIP joint. The most common joint to be affected in ankylosing spondylitis is sacroiliac joint. Very, very important. Ankylosing spondylitis can affect chest expansion. Ankylosing spondylitis can affect thoracic spine. Ankylosing spondylitis can affect lumbar spine. Ankylosing spondylitis can affect sacroiliac joint. But among this, which is an essential joint, without its involvement, you can never diagnose ankylosing spondylitis, sacroiliac joint. Sacroiliac joint. And gout, the question itself will go like this. The question itself will go: a 35-year-old businessman complains of pain next to the great toe. He had a recent business trip in which he consumed quite a lot of alcohol. That is how the question itself would be framed. So gout, great toe, G for G, gout for great toe. Other than this, Charcot joint, the most common cause of Charcot in this modern world is diabetes, and diabetes affect foot joint more commonly. So mid-tarsal joint is the most common joint. Otherwise, if they are asking any arthritis, pseudogout, hemophilic, septic, syphilitic, gonococcal, in all other arthritis, answer is knee. If it is a contagious spread, I said hip. If it is a contagious spread, I said hip. Coming on to all otherwise, the answer is knee. Osteoarthritis. What is the definition of osteoarthritis? What is the definition of osteoarthritis? Remember, osteoarthritis is a non-inflammatory degenerative condition. Degenerative wet condition. If it is inflammatory condition, there will be lot of blood flow and there will be bone erosion. If there is a non-inflammatory condition, will there be a bone erosion or bone formation? Will there be a bone erosion or bone formation? Bone formation. Okay, because we will be seeing that in questions. We will be seeing that in questions and x-rays. You will be seeing that in questions and X-rays. What are all the types of osteoarthritis? An osteoarthritis can be a primary osteoarthritis. It can be a primary osteoarthritis. It can be a secondary osteoarthritis. A primary osteoarthritis is because of aging and joint degeneration. A secondary osteoarthritis can be following a trauma. It can happen in endocrinopathies, congenital deformities, malignancy, metabolic causes. By the word metabolic causes, did they assess any metabolic causes of osteoarthritis in the past? Yes. Wilson's disease. Wilson disease, accumulation of dash metabolic product has lead to osteoarthritis. Copper. Kashenbeck's disease. Kashenbeck disease is because of deficiency of dash selenium. So these two metabolic causes has been assessed as of now. I told you what will be the finding in the cut section in a histology. Will there be any inflammation? No. Pathology wise, there will be new bone formation, and the cartilage will look wet cartilage on histology. What are all the features of osteoarthritis? Patient will complain of pain. Patient will complain of swelling. Patient will complain of inability to move the joint. There will be a characteristic deformity. In the hand. You will see Heberden node. Heberden node is an osteoarthritis of DIP. OA of DIP. Is there other node in osteoarthritis? Yes. What is that other node called as? Bouchard node. What does it indicate? Osteoarthritis of PIP. Osteoarthritis of MCP joint lead to dash node. DIP it is Heberden node. PIP it is Bouchard node. MCP joint involvement cause what node? Very good. MCP joint is completely spared. In the knee joint, osteoarthritis can affect medial compartment and can lead to genu varum. The most common cause of genu varum in adult is osteoarthritis. We have discussed that there. What is the most common cause of genu valgum in adult? Genu varum is osteoarthritis. Genu valgum in adult. Genu varum is because of medial compartment involvement. Guys, answer. Rheumatoid arthritis. Rheumatoid arthritis causes genu valgum. Osteoarthritis causes genu varum. So that is about the deformities that you will be seeing in knee joint and hand joint in osteoarthritis. What is the classification of OA knee joint? The OA knee joint, the classification is called as Kellgren-Lawrence classification. In Kellgren-Lawrence classification, it says in the first grade, all what you will be seeing is a minimal joint line reduction. Minimal joint reduction. Definite reduction. Definite reduction plus osteophyte. Definite reduction plus osteophyte. Multiple osteophyte. Plus loose body. Plus minimal deformity. Minimal deformity. So minimal joint line reduction, definite reduction plus some osteophytes, multiple osteophyte plus loose bodies plus minimal deformity, severe deformity. That is the Kellgren-Lawrence. So if you don't know what is Kellgren-Lawrence, it is not a problem. But Kellgren-Lawrence is associated with OA. If you know that name, that is more than enough. Divya, should I need to go further up or just that? Okay, perfect. So what are all the X-ray finding I am seeing in arthritis? Can you see the joint space is maintained here and the joint space is reduced there? Which compartment the joint space has reduced? Lateral compartment or medial compartment? Medial. So medial joint space reduction. Medial joint space reduction. Next, can you see a small bone spur? Yes, that is what called as osteophyte. Osteophyte. And can you see some whitening? Sclerosis because of new bone. Osteophyte is also new bone. And since it is a non-inflammatory, you will see lot of sclerosis. And one thing which is not given in this X-ray, which you can be seeing on osteoarthritis, is subchondral cyst. Subchondral cyst. All these are X-ray finding of osteoarthritis. A patient has come to you with osteoarthritis. Deformity genu varum. A patient has come to you with osteoarthritis. How would you manage? The patient has come to me with osteoarthritis. How would I manage? I would first say reduce the weight, take some tablets. Reduce the weight, take some tablets. Reduce the weight, take some tablets. See how kind people are. This guy is struggling, he is coughing in the middle. So should we help him? And they see how concerned they are, bringing me coffee. You guys having coffee? Sir, finish, sir, please, sir. How many of you are listening this in class? Sorry, at house. Sitting at house and listening. Man, you know what you should be doing? Don't sit in the bedroom. Go to the hall. Don't listen from headset. Okay. Take off the headset. Put it on speaker. And then listen and take notes. Let the house know that we are studying, man. Sunday evening we are working like a pig. Yes or no? And that will increase our reputation. Tomorrow morning when you are waking up, they will ask, do you need coffee? Do you need some tea? Whatever, anything. And my brother, when I was preparing for PG, every Saturday and Sunday he will ask me, Kathir, should I order some kottu parota from this hotel? Should I make sure that you are eating this fancy stuff? You know, expectation, let it increase. Yeah, we will fulfill it. I am confident you guys will win. And you guys are worried that expectation will increase. But what? Let me tell you something. Only if you create that hype, you will be fighting, or you would be, struggling to match that expectation. There is a saying, if you ask for something, if you firmly believe on something, that thing you will ask, you believe, you get, you receive. Yes or no? You firmly ask, you believe. I still remember one time during my PG preparation period, my dad was asking, Kathir, 6 months down the line, there is a marriage of your cousin, so you have to be attending. I said, like 6 months down the line, I will be in a PG institute. I may not have enough time during my first year of PG. My dad was looking me from top to bottom. Man, this guy is just studying. What kind of scene is he putting? But, but don't worry, da. What money are we losing in telling all these things? Just be hopeful. Okay, be hopeful. You ask, you believe, you will definitely receive. You will definitely receive. Okay, and also, even if you are not receiving it, your family will accept. My guy studied throughout the Sunday, from morning to evening, listening the class, repeating the class, revising the class, putting all questions with all the effort. My yacht didn't make it to that 3-digit rank. So, not a problem. Yes or no? Their acceptance will increase. Okay. So, if you are putting an effort, show the world. Don't be dull. Okay. So, reduce the weight of the patient. NSAIDs, IA steroid, hyaluronic acid, PRP injection, all these will work in early OA. If not, you have to consider surgery. What are all the surgical options available? High tibial osteotomy. When will you do a high tibial osteotomy? When will you do a high tibial osteotomy? The patient is very young. The patient is very young. And he is having only one compartment osteoarthritis. Young, medial compartment OA. Then I will do high tibial osteotomy. Why not a total knee replacement in them? If I do a total knee replacement for that person, he needs a revision in another 10 to 15 years time. He needs a re-revision in another 10 years time. And if he is only like 30 or 40, I can't afford to do a total knee replacement or any kind of replacement for a patient on 40s or 30s. So I will check whether it is only a medial compartment OA. I will confirm it with MRI. I will make sure whether all ligaments in a ligament stable patient, I will do a wedge. I will do a wedge and open a wedge, thereby that will open a gap in the knee joint. Can you see? I have created a wedge and that wedge has created some gap in the knee joint. This is what called as high tibial osteotomy. This is what called as high tibial osteotomy. And young medial compartment OA in a ligament stable patient, you can create, open a wedge medially. That is what called as high tibial osteotomy. That is what called as high tibial osteotomy. If the same medial compartment OA in an older individual, old but only medial compartment OA, only medial compartment OA, and ligaments are stable, then I will do the second procedure, which is unicondylar replacement. Unicondyle, just changing the medial condyle, just changing the medial condyle, just changing the medial condyle. If more than two condyles, are affected, which are two or more condyles are affected, two or more condyles, patient is too old, are also called as tricompartmental OA, Then I will do total knee replacement. Total knee replacement. And what is the approach? Medial para patellar approach. If I got to use a total knee replacement in young, what bearing surface will I use? Will I be using stainless steel, cobalt chromium, or titanium, or ceramic? If patient is too young with 2 or more compartment involvement, then you can't do high tibial osteotomy. Then you can go for ceramic. Whatever you do a total knee replacement, if you are doing posterior stabilizing total knee replacement, there is one complication which can happen. Any knee replacement, hip replacement will have complication of DVT, everything which we had dealt with total hip replacement. One characteristic complication of knee replacement was questioned recently, what that is called as patella-Klunk syndrome. What is patella-Klunk syndrome? In TKR, especially PS type, which means posterior stabilized type, the superior pole of the patella rub against the femoral condyle during extension. Rub against femoral condyle during extension. That is what called as patella-Klunk. That will give a clunk sound. That is what called as a patella-Klunk syndrome. In TKR, during a posterior stabilized knee, the superior pole of the patella rub against the femoral condyle during extension. The word extension is important. The word superior is important. Okay. Assessed question. Okay. So that is about osteoarthritis. Rheumatoid arthritis, the disease of arthritis of macrophage plus pannus, which means severe inflammation. It is inflammatory polyarthritis. Which age group is very commonly affected? It is very commonly affecting the middle age group, 25 to 55. Once the patient crosses 60, rheumatoid arthritis will reduce in its severity. It will remain static. So 25 to 55 year female. Guys, I think there might be some space restriction for you to write it here. Let me show you how to diagnose rheumatoid, or what are all the features of rheumatoid. Pretty much if you know the criteria, you can write the feature. You have to know 6 yes and 1 R. Number 1, stiffness. Stiffness is more than 1 hour in morning. So stiffness 1 hour morning. Stiffness more than 1 hour in morning. That is 1 yes. And that stiffness is present in a small joint. Example, hand. And it is present in several joint, which means multiple joint involvement. And this involvement is symmetrical in nature. So stiffness, several joint, small joint, symmetrical with an associated swelling. That swelling is called as rheumatoid nodule. Rheumatoid nodule. That swelling is called as rheumatoid nodule. And serological positivity, which means RA positive, and radiological positivity. So if you know this 7, that is all the criteria of rheumatoid. Stiffness, small joint involvement, especially the hand joint involvement, several joint involvement, symmetrical joint involvement, swelling, which is rheumatoid nodule, serology, which is RA positive, and radiology positive. If all these findings are there, out of 7, even if there is 4 out of 7, it is rheumatoid arthritis positive. It is rheumatoid arthritis positive. Okay, you need only 4 criteria to call or confirm it as a rheumatoid arthritis. What about the hand joint involvement? What about the hand joint involvement? Is this mallet finger? Yes, mallet fingers is totally different from swan neck deformity. Swan neck deformity is a deformity at DIP and PIP. A mallet is a problem only at the DIP and there is nothing in the PIP. Yes or no? Yes. So the hand involvement is swan neck, which is nothing but flexion at distal interphalangeal joint, DIP, distal interphalangeal joint, and extension at the proximal interphalangeal joint, PIP. Botanier is exactly opposite. Botanier is exactly opposite, which means flexion at the PIP and extension at the DIP. Botanier is opposite. That is all. Guys, you can't read everything. So just read swan neck and you can reproduce swan neck even in your exam hall. So just remember swan neck and think botanier is exactly opposite to swan neck, and you can answer whether it is a swan neck deformity or botanier deformity. Easy, right? Don't read everything. Swan neck, opposite is botanier. Other features, guys, in the whole of this textbook, I have never showed you a windswept deformity. In this whole of textbook, I have never showed you a windswept deformity. Yes? This is genu varum or valgum? Varum or valgum? This is genu varum or valgum? This is valgum, that is varum. So a same patient having valgum and varum put together, that is what called as windswept deformity. So in knee joint, it causes lateral joint reduction, can lead to genu valgum. It can also affect medial joint line, joint reduction, and cause genu varum, and it can thus cause wind swept deformity. Wind swept deformity. And the X-ray will show osteopenia, erosion, plus joint line reduction, Can any spine be involved in rheumatoid? Cervical spine. Ankylosing spondylitis, sacroiliac spine. In rheumatoid spine, C-spine involvement is common, which means atlantoaxial joint. Osteopenia, erosion, and joint line reduction. Now, is there anything other than joint that rheumatoid can affect, which means extra articular manifestation? We already discussed nodule can be there in the subcutaneous plane. Sjogren syndrome can affect happen in rheumatoid. Sjogren. What is Kaplan syndrome? Medicine question, guys. Rheumatoid plus pneumoconiosis. RA plus pneumoconiosis. Yes, Kaplan syndrome. What is Felty syndrome? RA plus neutropenia. Yes, RA plus neutropenia. It can cause vasculitis, lung disease, heart disease, etc. So, rheumatoid can damage vessel, it can damage lung, it can damage heart, it can cause blood, it can create problem with like pneumoconiosis, it can produce syndrome like Sjogren syndrome. Sjogren syndrome. And what is the single cell which you will see abundant in a rheumatoid? Macrophage, which we have written already here. It is an arthritis of macrophage and pannus. It is an arthritis of macrophage and pannus. What other investigation will you do? One is RF factor, rheumatoid factor. Rheumatoid factor is most sensitive parameter, but the specific is anti-CCP. Specific parameter. So we will do RF factor anti-CCP. We will do RF factor and anti-CCP. Okay. You will see macrophages. You will see macrophages. You will be seeing pannus. Pannus is nothing but a thick inflamed synovium, which is a cause of pain. The pannus is the cause of pain. Cause of pain. What is pannus? Which is nothing but synovitis. Hope you will all see that. And X-ray findings we have written previously. And how would you manage? Disease modifying agent: hydroxychloroquine, sulfasalazine, methotrexate, leflunomide, infliximab, etanercept, golimumab, abatacept, anakinra, rituximab, tocilizumab, synovectomy, total knee replacement, and deformity correction surgeries. Total knee replacement and deformity correction surgeries. And what are all the factors which determines the poor prognosis of rheumatoid? Whenever there is a RF positivity, it is a poor prognosis. Whenever a person, the mnemonic is RA1, RAONE. Acute phase reactant is a poor prognostic factor. 1 year duration, poor prognostic factor. Nodules are present, poor prognostic factor. Erosion, high ESR, and economically weaker background, poor prognostic factor. Why economically weaker background is poor? Man, even last week I was doing a class, face-to-face class in Chennai, and after finishing the class I got to attend a conference. So I did go and attend, and they were talking about golimumab. Then I asked what is the rate, and they said 28,000. Every month you are going to spend 28,000 onto a tablet or onto an injection. Do you think economically weaker section can afford all these biologicals? So being an economical weaker population itself is one of a poor prognostic factor in diseases like rheumatoid, where all biologicals are used and biologicals are very expensive. But I was actually happy hearing that rate, because last year the same golimumab in Chennai was costing 54,000. This year at least it is 28,000. You guys getting the point? So why economically weaker population is still a poor prognostic factor? and tendon damage in rheumatoid, extensor pollicis longus. What other hand deformities can happen other than swan neck deformity and botanier deformity? Z-shaped deformity, ulnar deviation, arthritis mutilans, or hand severe hand deformity. Severe hand deformity. So the person hand will be like this, ulnar deviated, Z-shaped, in a weird ways. In a weird way, it will be. So rheumatoid is a serological positive arthritis. There are certain serological negative arthritis, and that will affect the spine predominantly. So what are all the serological negative spondyloarthropathy? Previously when we were reading, the mnemonic was RAPE. R for Reiter's, A for ankylosing spondylitis, P for psoriatic arthritis, and E for enteropathic arthritis. But now at least we have developed some sense to name the mnemonic as PAIR, P-A-I-R. P for psoriatic, A for ankylosis, I for inflammatory bowel disease related, and R for Reiter's disease. So psoriatic, ankylosis, inflammatory bowel disease, and Reiter disease are seronegative spondyloarthropathy. Now coming on to the next disease, which is ankylosing spondylitis. Are you guys with me? Sleeping? Yes? Yes, guys? Do you have any doubts? Did I explain completely rheumatoid, the hand deformities, the leg deformity, the serological parameters, the X-ray findings, the histological findings? Everything was explained. And the drugs, don't ask me to talk about the drugs alone. That itself is like 2 hours topic. Biologicals. If they give me 4 days to talk orthopedics, then I will be talking about all the tablets. Okay. And it is usually discussed in pharmacology, right? Disease modifying agent, DMARD, monoclonal antibodies, golimumab, all those MABs are discussed in pharmacology. Okay. So I'm not pushing there. Coming on to ankylosing spondylitis. Ankylosing spondylitis is also called as Best-Dru's disease. It is also called as Best-Dru's. It is also called as Best-Dru's disease. It is also called as Best-Dru disease. Also called as Mary-Strumple disease. Mary-Strumple disease. Ankylosing spondylitis is also called as Mary-Strumple disease. It is a male predominant disease and it is in the younger age group, like 25 to 45. Younger age group males are predominantly affected. And what is the feature? See guys, the criteria is Basdai criteria and modified New York criteria. So many criteria. You don't need to know the whole criteria, just the name, more than enough. But what is the feature? The problem of ankylosing spondylitis is inflammation of tendon inserting site. Inflammation of tendon inserting site. If you see this vertebra, the pelvis and sacrum are connected so close to each other, and lot of tendons would be going and connecting the pelvis sacroiliac joint. Do you all agree? When compared to this part of the spine, this part is having lot of ligament connection. Yes or no? To keep that region stable. Yes. So basically ankylosing spondylitis is a disease of enthesopathy or tendon. enthesopathy, tendinitis, which is more common in sacroiliac joint. So the most common joint is sacroiliac joint. So the most common joint is sacroiliac joint, and then it ascends up slowly. Ascend up slowly. Thereby it can affect lumbar. So it will affect like minimum 4 vertebra. Minimum 4 vertebra. Ascends up slowly and affects minimum 4 vertebra. And when it affects lumbar, it is called as Schober test. It is called as Schober test. Then it can go up to thoracic. In thoracic, it will cause restricted in the chest expansion. Restricted chest expansion. Okay. So, Westrumary-Strumpel disease, male, 25 to 45. Criteria is Basda and modified New York. It is predominantly damaging the tendon insertion site, which is maximum among the spine. It is maximum in the sacroiliac joint. So the most common joint is sacroiliac joint, and it slowly ascends up and affect at least to 4 vertebra. It affects at least to 4 vertebra, and when it goes to lumbar, I will assess with a test called as Schober test, and when it goes to thoracic, it will affect the chest expansion. So I will measure the chest expansion. This is Schober test. This is Schober test. Okay, Schober test. This is Schober test. Now, I have told you the assessment of lumbar vertebra. I have told you the assessment of thoracic vertebra, but I haven't told you the assessment of sacroiliac joint. Hyperextension test are also called as Jenslen test of hip. Patrick test or figure of 4 test. Patrick test or figure of 4 test. Okay. Okay. That is what ankylosing spondylitis. Guys, don't worry. More of a theory. But this will all help you with the questions. We will be discussing questions. Don't worry. Okay. We will discuss all these with questions. There is one QR code here. If you scan that QR code, it will take you to a YouTube page of mine. There I have actually explained you what several points about Thomas Splint, several point about BB Splint, and that channel has quite a lot of orthopedic content videos. Okay, but this QR code will take you specifically to ankylosing spondylitis. I will explain in detail about ankylosing spondylitis, why every single sign is happening, but you don't need that much amount of details for why every single sign is happening. So to your level, you should know ankylosing spondylitis, investigations, basic. Serologically, it has HLA B27 positive. HLA B27 positive. Nearly 90% of the patient will have HLA B27 positive. 90% of the population ankylosing spondylitis will have HLA B27 positive. And the named X-ray findings would be bamboo spine, Romanes lesion, squaring of vertebra, dagger sign. trolley track sign. Trolley track sign. But the earliest feature is none of this. Earliest feature is sacroiliac joint inflammation. Sacroiliitis. Sacroiliitis. Sacroiliac joint inflammation. Earliest finding is sacroiliitis. Sacroiliitis. Earliest feature is sacroiliitis. Okay. And investigation of choice, MRI. Investigation of choice, MRI. Okay. Yes. Any questions? How will you manage ankylosing spondylitis? Same like rheumatoid, but usually not methotrexate. You will manage with the NSAIDs. If not working, you will go for biologicals. No role for methotrexate. No role for methotrexate. Remember guys, today while discussing about millar hiostosis, I said candle wax dripping appearance. And today while talking about some other place also, I was telling about diffuse idiopathic skeletal hyperostosis. Diffuse hyperostosis, that is dish. Okay, this dish will also cause candle wax dripping appearance. Remember, dish or Forsythia disease, also called as ankylosing hyperostosis, it is all same and the name mimics like ankylosing spondylitis. But how to make a difference? An ankylosing spondylitis is a young age disease. This is a old age disease. Ankylosing spondylitis is a sacroiliitis positive condition. Ankylosing hyperostosis is a thoracolumbar condition. Chest expansion is more affected here. It is less affected. Every symptoms are less here, less affected. Tenderness is more here, less here. ESR is more elevated here, less elevated here. HLA B27 here and B8 here. Syndesmophyte difference is, in ankylosing spondylitis, the syndesmophytes are marginal. And in dish condition, it is non-marginal. Guys, don't worry. I will show you dish image. I will show you ankylosing spondylitis image when we are discussing questions. Okay. Coming on to psoriatic arthritis. Don't worry guys, in tumor there is very lot of just concepts, facts and one-liners. So we will just brush aside with the tumor, and at the end of the tumor there is two tumor I want you to know in detail. One is an osteoclastoma and other would be an osteosarcoma. Okay, we will deal with that tumor in detail, and with other tumors we will be reading what are all the significant salient points, and we will be discussing questions on tumor, because tumor, the problem with the bone tumor is it is not a difficult topic to discuss, but it is a very difficult topic to answer. So when it comes to tumor, again we will study the subject and then we will put questions. and try to answer the questions by that. That is how you should be reading a bone tumor, with which we'll finish the class. I am expecting in 1 hour time we should be good enough to finish. Okay. Psoriatic arthritis. Psoriatic arthritis, again the criteria name alone is more than enough. Casper's criteria, and I previously told you it has no sexual predilection, and the most common bone to be involved is DIP. So what finding will you be seeing? Pencil in the cup finding. If you have never seen a pencil in the cup, I will show you. Can you see that pencil in the cup there? Yes. DIP joint, pencil in the cup. Yes or no? Yes, that is the classical pencil in the cup sign. And sausage digits, this is how a sausage digit would look. This is how a sausage digit would look. And arthritis mutilans, this is how a mutilated arthritis would look. Okay, and what are all the differential diagnosis for arthritis mutilans? I did talk about arthritis mutilans when I was talking about rheumatoid. So rheumatoid, psoriatic and juvenile chronic arthritis can cause arthritis mutilans. Can cause arthritis mutilans. Can cause arthritis mutilans. Treatment of choice, again for psoriatic arthritis, you will start with methotrexate. But you need to do secukinumab, ustekinumab, all these things, NSAIDs, hydroxychloroquine, and you need to treat the psoriasis as well, which means PUVA therapy, phototherapy, and retinoids. The treatment of psoriasis, I leave it to dermatology people. Coming on to gout. Gout, can you see in gout the osteophytes are overhanging edges? The osteophytes are literally falling down from the joint. Yes or no? That is classical for gout. Osteophytes falling down from the joint in the first metatarsal. So the question itself will start like, a 35-year business male after alcohol episode complains of great toe pain. What is the treatment? What is the diagnosis? That's how they would be discussing a gout question. That's how they would be even starting a gout question. Clear? That's how a 35-year business male after alcohol, a great toe pain. What is the diagnosis? Answer is gout, and that acute gout is what called as podagra. Acute gout is what called as podagra. In acute gout, if you do a fluid analysis, what kind of crystals will you be seeing? I will be seeing negative birefringent uric acid crystal. Uric acid crystals are needle shaped crystals. Needle shaped crystals. Needle shaped crystals. Yes or no? Yes. And I will be seeing the overhanging edges. That is number one. Other than that, I will be seeing a big swelling in the body. That is called as tophi positive. Tophi positive. In which condition you will see tophi gout? In which condition you will see tophi gout? And what is the treatment? NSAID, colchicine, steroid, and drugs like allopurinol, febuxostat. Allopurinol, febustat. All these are treatment for gout. So how would you differentiate a gout from a pseudogout? I said it is negatively birefringent uric acid crystal. Then pseudogout is exactly opposite. Positively birefringent calcium pyrophosphate crystal. This is needle shaped, that is rhomboid shaped. So rhomboid calcium phosphate crystal. which is positive birefringent. Positive birefringent. What is the most common joint to be affected in gout? Great toe. What is the most common joint to be affected in pseudo gout? Knee joint. What is gout associated with? Alcohol and other diseases. But what is pseudo and uric acid diseases? What is pseudo gout associated with? Thyroid, parathyroid diseases. What will be the X-ray finding? Erosion, because gout is inflammatory condition. What is pseudo gout? It is deposition of calcium, so you will see sclerosis or chondrocalcinosis. That is about gout and pseudo gout. If at all you are seeing a pseudo gout of the shoulder, that is what called as Milwaukee shoulder. The differential diagnosis for chondrocalcinosis I have given. So whenever you are seeing a pseudo gout, you should evaluate thyroid. You should evaluate thyroid. You should evaluate thyroid, parathyroid. You should evaluate thyroid, parathyroid and other metabolic diseases. Neuropathic joint. What is neuropathic arthritis? When a patient is coming to you with such a gross X-ray, and if you ask, sir, is it painful? And he would say, it is not painful, but I am finding it difficult to walk. So the sign is more than the symptom. Sign is more than the symptom. So sign wise, the person will have a very bad disease. But if you ask what are your symptoms, he say painless, pain-free. Because no functional nerve. No functional nerve. At this point, you cannot help the patient by any revision, replacement or anything. Either you should do amputation or you can do arthrodesis. So either treatment would be either amputation or arthrodesis. Nothing else will be of any help. Nothing else will be of any help. Okay. Now, what is the most common joint to be affected? There are 4 causes I have given. What do you think is the most common cause in this modern world? Tabes dorsalis is due to syphilis, leprosy, syringomelia. Do you think any of that is common? No, diabetes. So nowadays, if they are saying neuropathic joint or Charcot joint, it invariably means diabetic arthropathy. Diabetic arthropathy. So it is foot joint involvement, which is mid-tarsal joint. If at all Tabes were involving, which joint would be more commonly affected? Knee joint. If at all leprosy is affected, hand joints. If at all syringomelia, shoulder. Otherwise, if they are asking you what is the most common joint to be affected with neuropathic joint, mid-tarsal. No role for replacement. No role for arthroplasty. Don't say, sir, Charcot arthropathy, I will do total ankle replacement. No role. No role. Hemophiliac. Hemophilia. See, there is lot of blood accumulated there and the blood flow is massive because the blood is not going to clot. It's just come and go, come and go, come and go, and it's not going to stop. So erosion will be massive. Yes or no? Can you see that the bone is completely eroded? Severe inflammatory arthropathy. Hemophilic arthritis. And due to which factor deficiency? Hemophilia is due to which factor deficiency? Hemophilia is due to factor 8 deficiency. You will be seeing squaring of patella. Squaring of vertebra is seen in ankylosing spondylitis. Squaring of patella is seen in hemophilic arthritis. Squaring of patella. Okay. Can you see the notch, intercondylar notch? Wide intercondylar notch. Arthroscopy is contraindicated. Arthroscopy, any joint injection, anything is contraindicated because it bleeds like crazy. Arthroscopy is contraindicated. Joint injection, arthroscopy, everything is contraindicated. The same hemophiliac can bleed onto the muscle. If at all it is involving muscle, that will create a tumor like swelling. That is hemophiliac pseudotumor. And which muscle is most commonly affected? Iliopsoas. Which muscle is next commonly affected? Quadriceps. Although this is a pathology question, most often this will not be discussed in pathology. So let me tell that unfinished arthritis. Are you guys done with arthritis?